Socket preservation graft is a very common and, in my opinion, a must procedure after tooth extraction. And that's because bone atrophy and remodeling following tooth loss is inevitable, but it can be minimized by choosing the right socket preservation technique and material. Now, the most common techniques that we use for socket preservation are the conventional GBR techniques, using some type of bone graft material in combination with either a membrane or a collagen material. Today, I'm going to tell you about a different kind of material that is not so much a bone graft, but rather a bone stimulating material called foundation. It's an easy, effective, and a less costly approach to socket preservation. And I'm going to show you how and when we use it. So let's get going and see what's on our tray. When it comes to socket preservation or augmentation, we have many materials to choose from. We can use either autogenous, allogenic, xenogenic, or alloplast materials in either a particulate form or a putty form. And we can use them in conjunction with either GBR membrane or an occlusive collagen material that helps to contain it. Now, typically, such materials need about 4 to 6 months of maturation as the graft is gradually replaced by osteoblast and a natural bone is formed. This is a process that's called creeping substitution. Of course, the selection of the bone graft material, membranes, incision design, flap design, and the surgical approach itself should be based on the socket deformity and the number of walls that are involved in the defect. So there is no one technique or material for all defects. Today, I'm going to talk about a unique product called Foundation from Morita, which is actually not a bone substitute, but rather a stimulant for bone regeneration. Foundation is a collagen-based bone-filling augmentation material, which is composed of ethylocollagen that has been cross-linked by heat treatment in order to achieve its biocompatibility. It consists of a fibrillar and a heat-denatured ethylocollagen. The fibrillar ethylocollagen provides a scaffolding for the surrounding cells, and the heat-denatured ethylocollagen stimulates the infiltration of the cells into the product. Foundation is helpful in maintaining bone after tooth extraction. It can be used as a pre-implant augmentation, as it will stimulate the bone to fill in, allowing the implants to be placed perhaps sooner, as in some cases as early as 8 weeks. It can also be used for pontic site development as well as for third molar extractions in order to ensure that we have a good bony support on the distal aspect of the second molars. Now, if you have a larger defect with deficiency of one or more walls, foundation by itself is probably not the right material or technique, while it can be used in conjunction with other bone graft material and membranes in those cases. So primarily it's indicated in 5-wall defects for preservation and stimulation of the bone regeneration. Foundation comes into 2 sizes, a small and a medium size, which are basically shaped like bullets for easy placement into the socket. It comes in a sealed and a sterile package, which is opened, and the capsule that's holding the material is dropped onto the sterile tray. To get the material, simply snap the container open. Now I use a hemostat to remove it from the container and avoid touching it unless using a sterile surgical glove. Now, once the material is removed, I carry it to the extraction site and then use my bone condenser, either a Sinus RC5 instrument or a Sinus 7S bone packing instrument, in order to position, pack, and burnish it into place. Generally, we don't need to raise a flap, but I do undermine the gingival margin around the socket very slightly by about 1.5 millimeters to 2 millimeters, and that allows me to slide in the edges of the material under the tissue for better stability. And I use both sides of my instrument to pack and burnish the material in. I do like to place a resorbable suture in order to stabilize the tissue and the material. Now I have tried the 3O chromic suture, but I think it dissolves a bit too soon and prefer to have something that's a bit longer lasting. So I generally use a 6O glycolon suture, which is a monofilament resorbable material, and it maintains itself for about 3 to 4 weeks. Now it's okay to leave the wound open, and primary closure is not necessary, as the site heals by secondary intention, generally in about 4 to 6 weeks. And this is one of the advantages of the material, as it allows the regeneration of keratinized soft tissue without the need to do flap advancement, which will change the position of the mucogingival junction and also will result in a narrower zone of attached gingiva. This way we can keep the tissue architecture and optimize the zone of attached gingiva, which is very important for support of the implant and the restoration. Now, how about sockets with wall defects? Well, in these cases, I use my conventional particulate bone graft and membrane for the wall and socket augmentation, and then use the foundation on the crestal aspect. Again, this way I can keep the wound exposed and avoid the flap advancement. And this combination approach restores the bone and the wall defect, but also allows the regeneration of the soft tissue and the keratinized gingiva right along the crest of the ridge. Generally, I ask patients to keep on soft and liquid diet for about 3 weeks in order to avoid trauma to the tissue during the initial healing phase. Now for sockets with pure foundation graft, I generally re-enter the site in about 3 months for the implant placement. But if I've used that in conjunction with a particulate bone graft, then it's best to wait about 4 to 6 months as we do in routine GBR cases. I like the foundation material for its handling, ease of placement, the ability to leave the wound open for secondary intention healing, as well as its bone stimulating property. On re-entry as early as 3 months, I have noticed the bone to be quite mature and hard for implant placement, with good preservation of the ridge and the soft tissue. The surgical technique is typically simpler and faster to perform. It's also less costly for the patient, and I think it offers a more rapid recovery due to its minimally invasive approach, which does not require extensive tissue flaps. Now you can find the link to the foundation bone graft in the video description. If you like this episode of What's on Our Tray, hit that subscribe button below and stay tuned for our next episode. And if you want to see more demonstrations, case presentations, and more in-depth conversations and discussions about this material, please join us on our site, facialartdentalforum.com. Thank you, and see you again on our next episode of What's on Our Tray.